and hence the topic of breaking bad news. I think it becomes the mandate of the oncologist who treat cancer day in and day out to break certain bad news to our patients. But before we go any further, would really like to know from you. What is your opinion in that? Sorry? Anything that can be adversely affecting the person's future in an adverse manner would be considered as bad news. So in our profession, we do deal with bad news ever so often, and that you see in clinical practice. When do you see that effect? When do you have to part with some bad news? Any kind of diagnosis? Yeah. So it's like you have to share, and there is a thing also. Is this working? Yeah. Pointer भी है? Pointer. अच्छा, ठीक है. Yeah. So can we just, you had your share of sleep, now you can keep quiet and listen also. So it's like when you have to share diagnosis, any illness is not good news, certainly, even if it's a small illness or a non-communicable illness or a long-standing illness, whatever. Then when patients show clinical progression or death, as you put it, they are all bad news. We oftentimes find it difficult to part with bad news or to share the bad news with the patient or attendant. Why is that? Somebody else. Why do we find it difficult um, to give bad news? Okay. Anybody else? Excellent. So basically we are worried that बहुत ज़्यादा intense reaction हो सकता है. They may become violent. They are also not trained after all. And we are certainly not been trained. Nowadays in the undergraduate course curriculum, there is a lot of emphasis on communication. But earlier times, certainly it was not there. And that is probably the reason why, I mean, it is the lack of communication which is causing this rift between us and the society. And we hear ever so often these very, very disillusioning and demoralizing incidents where doctors are beaten up and all. Half the time, as some people who have seen a lot of clinical medicine over the decades, one feels that probably these incidents could have been averted had there been proper communication between the doctors and the patients and their family. The other thing that we find is that we are not we because we are not formally trained, we do not know how to individualize for each situation or patient. This picture was just to show that if I was asked to repair my car, I would not be able to do it because I'm not formally trained. And this boy, he's probably 10th pass or something, and he would do it with the ease and elan that most of us would lack. So it's just that formal training makes all the difference. And hence, this lecture and the lecture before, which Dr. Shubha had taken about communication and how very important it is in our profession. So let's look at how we should look at bad news and share it from the look at it from the patient's perspective. If you are supposed to share bad news, which is like really bad, say for instance in my field, it's cancer. You have to tell. And actually speaking, for us, the patient comes with the diagnosis report, and then we are supposed to treat. But for most of you who are sitting, who are basic surgical or medicine specialities, you are the ones who would have to sit in the OPD to share, to tell them about the diagnosis which they have not come prepared for. At least nobody would want कि मेरे को कैंसर डिटेक्ट हो जाएगा ऐसे करके, वो सोच के तो नहीं आएगा. So that is the reason you should also be equally adept at dealing with situations like that. Remember, this a diagnosis such as, let's, because it's the most dramatic of the examples, the diagnosis of cancer, if the patient has to hear that, it is going to create a big upheaval in the patient's uh, life at that particular time. Why? Because suddenly there is, it's like as if somebody's pulled off the rug from under the feet, and there is a complete loss of control that the patient feels, apart from the stigma and all. It's a blow to everything that he had planned out in his immediate or distant future. More than that, you also must remember, as doctors who are parting with this bad news, that you would be sharing not only just this vital piece of information, you will also be talking, telling them कि अच्छा ये diagnosis है आपका, आपको ब्रेन ब्रेन ट्यूमर है या ब्लैडर कैंसर है, उसको हम ऑपरेशन करेंगे, फिर उसके बाद उसका सिकाई करेंगे या उसकी कीमोथेरेपी देंगे. So these are new words for them. It may be like you and I, we've been brought up on the staple diet of these words and jargon, but उनके लिए ये बहुत नए हैं. And so you are sharing lot of information which is completely alien to them, in your style. And he, on the other hand, the person who's sitting across the table, he is undergoing a maze of emotions कि क्या होगा, will I live, ये ठीक भी हो जाता है, मतलब सर्जरी का क्या मतलब होता है, सर्जरी कितना बड़ा होती है, रेडियोथेरेपी होती क्या है, कीमोथेरेपी क्या चीज होती है. So there are a lot of things happening in this cranium of his, and you are sharing more and more information, so he can take as much, not more. These are things that we need to understand as doctors who are going to share information. From the patient's perspective, if we see, well, let's put it, anybody who has to be the recipient of bad news is that patient or his or her family is not going to, is not going to feel great about it. It is oftentimes devastating piece of information, health information, and nobody is going to feel great about it. But at the same time, we must also, as diagnosticians and clinicians who are sitting to share this news with them, we must understand that each patient is unique, and we have to adapt to their unique style. Why unique? Because they come from different age, different education, family values, professions, the baggage that they are carrying. Somebody who says कि मेरे गांव में एक कैंसर का हुआ था, वो बिल्कुल ठीक हो गया, मतलब वो 2 महीने आया, उसने ठीक इलाज किया, वो ठीक हो गया. He comes with a positive set of values with you. The other one says मेरे गांव में आया था, 2 मरीज आए, दोनों की डेथ हो गई, ठीक ही नहीं कर पाई ये डॉक्टर. So he's come with a huge negative baggage for himself. So you, as person who's trained, person who's experienced in dealing with such situation, would have to deal these patients differently. A young girl, for instance, of say 25 years and a elderly man of 82 years, both have been diagnosed of cancer. Needless to say that their reactions to the same diagnosis would be so different. Their family's reaction, 82 का ठीक है, जिंदगी जी लिया उन्होंने करके, and whereas a young 30-year-old just married with a few months old baby is going to react differently. So we have to adapt to their unique situation, and then share the information accordingly, individualizing for them. What should we expect? Most often we would expect, we've all read this, nothing new, that when you share a bad news, which is actually a major health event in the patient's life, you are likely to expect certain reactions like shock and denial, anger, bargaining, depression, and acceptance or peaceful resignation. These are five set of reactions which you are supposed to see in a temporal sequence. Like when you share the diagnosis that आपके husband को cancer है, तो you will expect, or the patient, if you are sharing it with the patient, you can expect that there is sudden shock or denial. मतलब ये क्या बोल रहे हो आप? नहीं, ऐसा तो हो ही नहीं सकता, आई एम परफेक्टली फाइन। आपकी स्लाइड्स जो आपने टुकड़ा भेजा था वो तो नहीं एक्सचेंज हो किया, कुछ गलत रिपोर्ट तो नहीं आ गई है। सो दैट काइंड ऑफ रिएक्शन यू कैन एक्सपेक्ट। देन देयर इज एंगर, व्हाई मी, मतलब मैंने क्या किया, मैं तो ना तो स्मोक करता हूँ ना कुछ करता हूँ, व्हाई मी। देन बार्गेनिंग, कि देख लीजिए आप दोबारा से, कुछ हो सकता है कि उतना बड़ा ना हो जितना आप सोच रहे हो, उतनी बड़ी प्रॉब्लम ना हो। सो ही इज मेंटली हैगलिंग, ट्राइंग टू कम टू टर्म्स विद इट। Then there's nothing that you can do about it. You are starting to beginning to accept with a negative emotion in place. Very few patients or their attendants would reach to a stage of peaceful resignation, that this is it, this is what we have, and this is what we make the best of it. He's lived long, he's lived a complete life. So few patients reach that. Now, again, this each individual patient is so unique. You'll find that these reactions, you might not see shock or denial in some patient, or you might see anger first and then denial later. So these things, they have, you may see these gamut of reactions, but it may not be in the sequence that has been mentioned. It may be that one denial is so strong that it goes on for months altogether. So that kind of picture you might see, and you should be mentally prepared for that. What should be our goals while we are breaking bad news? We have to accept that we have to explain as simply as possible to the patient and to the family, support them in this hour of need, avoid any overwhelming sort of distress that they might have, or prolonged denial, and also offer realistic or truthful hope. Now, these are easier said than done. Sometimes the reaction may be so violent that you're not able to handle it. So, more important it is, after the point number 2, that is support, you should also be able to preempt how much the patient or the patient's caregivers are able to digest or withstand that piece of information. If you feel that that is not what they are ready for today, then it is better to put a stop on this counseling session and call it for another day. We'll see as we go along how we can do it. So, just to facilitate the breaking of bad news, we have to learn to understand the patient's perspective. Why? Because, see, the patient actually is there. He's come all the way from his village to sit in front of you to understand the information that you are going to give. So, give it as simply as you can put it. You have to have some kind of degree of caring approach, hopefulness, and put in a set of he should feel confident that what can be done will be done. So these are all not just to be said in words, but these are also that can be judged from your tone, your body language. So non-verbal communication, which is what Dr. Ma'am Shubha Ma'am would have talked about, the non-verbal communication comprises two-thirds of your communication skills, and that should be in place for you to be able to part with bad news time to time in your clinical practice. The other thing that is important is that we must understand, although we all work in a huge organization like this, and so I took the biopsy, you reported, somebody else is going to sit down in the OPDs. When the patient came the first time, senior doctor was seeing, talking to them. Then when the report came, the doctor has gone for lunch, the senior doctor. Now a new entrant is sitting, and he says ki nahi aapko to cancer hai. Neither he knows the whole history nor the complete details, but he's parting with information. The patient, however illiterate or poor he may be, but remember, at the end of the day, the person, he's a human being who's sitting across the table. There are certain emotions, feelings, and he has a whole story to himself, attached to himself. There is a level of expectation from him as well, from you, that the person who's sitting and explaining to him is somebody whom he can feel confident about, and is a bit familiar. Every now and then a new face. You were sitting, and it's time, because you haven't had lunch till 4 o'clock. You say, चल यार तू देख लेना इस पेशेंट को, रिपोर्ट बता देना इसको. It's not like that. It has to be more humane than that. You spend those, if you can wait till 4 o'clock, you can wait till 4:15. You have been talking to the patient earlier on, spend those 15 minutes explaining to him, and then go for lunch. That is what one is trying to sort of emphasize upon. From the patient's perspective also, you have to give him time to talk it out and express his feelings, because it is not what he wanted to hear in the first place. Now that he has the diagnosis, he would like to tell about his side of the story as well. Please be patient and listen, hear it out. Then comes, again we come back to the same question: who should be breaking the bad news? Any takers? You all have just joined, na? All of you. So if we just talk about, say, cancer, most of you, all of you are in clinical specialities. You will be dealing with cancer in some way or the other. So if you have to part information regarding the diagnosis of cancer, somebody who's, generally it is said that, who has seen the natural course of events in that particular illness is a better person to share this news with. So it's it's somebody who's reasonably senior and will stay. I am the MCH student, and I have exam in 3 days time. So I will part with the information and go away, and the patient will be found hunting कि वो डॉक्टर सो एंड सो को ढूंढ रहे हैं क्योंकि उन्होंने ऐसा बोला था, अब उनसे हम कुछ सवाल पूछना चाहते हैं. So that's not the correct thing. So it's generally believed that somebody who's been there for some time and will be there for some time is a good person to explain the diagnosis to the person, to the patient. It need not be somebody without hair like this. So the important thing is that seasoned people would be a better idea. There is a formal way of breaking bad news. Obviously, we also abbreviate it when we sit in our heavy OPDs, and abbreviate it to the extent that it is uncomfortable for the patient. And then there is a level of unmet expectations that we ever so often see in our clinics. So there are multiple models that have been proposed as to how you share bad news. But the most common one is the spikes model, which is a 6-step process where you set up the interview, you assess the patient's information, invite him that I'd like to share the information with you, and then part with knowledge, and then address his or her emotions, and then strategize and summarize. So what do we understand by setting up of the interview? So each counseling session or breaking bad news session is an independent session on its own, where you prepare in advance. And so you are supposed to have it as privately as possible, one to one, patient sitting at the same eye level as yours. It's not a great idea that the patient is lying down on the couch, examination couch, and you are standing, and then you are explaining the diagnosis to him or her. That's not on. It should be at the same eye level. If you are sitting down, he should also be found sitting, because that brings in a feeling of equality amongst patient. Avoid phone calls, something that I don't know about others, I am really culprit to. When you are sitting in the heavy OPD, there is a landline which is ringing, your CUG which is ringing, and there is your personal phone, which also half the hospital has it, is ringing, and then you are sharing this information. That is disrespect to even the patient's so vital information that you are doing. And as far as possible, one should avoid it to the extent possible. You should also be cognizant of the fact, keep cognizance of the fact that um, which family member to share this information. Oftentimes they come with somebody, some friend, some village um, inhabitant or whatever, and so it's better that you ask them कि आप कौन हैं, क्या लगते हैं मरीज के, and then with the person whom the patient would be more comfortable with and who has the right to this information. Remember, this information is not a small news for them. Once it goes out, um, if it's a village common, a neighbor who's standing, or a friend who's standing, he may go and share it with people that the patient may not want. So we have to kind of assess who would be the best person. Naturally, immediate family members are the best people for you to share that information with, and your tone should always be correct. Whatever you can offer needs to be uh, also expressed in the tone. You have to give adequate time. Your body language should be um, good. I mean all of us. If I am sharing कि okay आपको cancer है and I'm looking अच्छा, okay, I have to go, that's not on. He may be whoever he is. He may be a poor villager, but then even then he understands that okay, ma'am has other preoccupations other than my diagnosis. For him, his diagnosis, remember, is the most important thing. Then you have to kind of gauge, or you have to gauge the gap in information. You have to tell him, the patient or his caregiver, that they have cancer. Now, to tell him, you have to evaluate first based on your experience and by talking to them in general, how much they know, how much they are expecting, how much they are wanting to know. All these things in 2 3 sentences you have to gauge, and that is a very important turning point, because that, if the patient is completely unprepared and you share everything with them or lot of things with them, then it can backfire with uh, notwithstanding your all good intentions and knowledge and experience and the desire to share well. So once you know that yes, they kind of have an idea that it may be not good news, then you have to invite them that would you want to listen? Because remember, in the court of law, the patient and their attendants have the right to know their diagnosis. At the same time, there may be, in patient's case, I would say, they have a right not to know if they are not prepared. And it is the duty of the treating or clinicians that you gradually prepare them for knowing their about their illness to the extent that is possible, given their unique circumstances. So you have to kind of listen to and look at the patient cues all the time when you're sitting in your clinic. Now comes how to share the knowledge. Well, if it is not good news and you know that they are kind of prepared, you still have to start with a preamble that unfortunately it's not very good news, so that it it gives them those few seconds to compose themselves. And remember, repetitions and pauses are very important when you are parting with such information. When you say that you're not problem zyada serious hai, and then go on to something else, give a breather, pause. The information will percolate down, and then the patient or the caregiver would be more composed to listen to what you have to say. Be simple, clear, polite. बहुत ज्यादा इंग्लिश या बहुत ज्यादा टेक्निकल लैंग्वेज नहीं यूज करने का. You have to keep it simple and in the in the style or language that the patient understands. The pace should be at the pace is not to be determined by you or the lack of time that you have or the next class that you are about to attend. The pace is determined by patient because it depends upon their comprehension. How much they are able to grasp, that will determine the pace. It is wise to provide information in small chunks. I mean, I can sit and have a counseling session for about 50 minutes or 1 hour explaining from beginning till end. But I mean, आप लोगों की attention span 40 minutes नहीं रहती, 5 o'clock तक तो आधे सो रहे होते हैं, तो उनका कैसे हम expect कर सकते हैं कि they will be able to comprehend all that 1 hour of what you have to say. So give it in small chunks. Maybe in the first visit, this much is enough कि आपको ये बीमारी है, लगता है फैली हुई है या नहीं फैली हुई, and possibly सर्जरी एक ट्रीटमेंट है, उसके बाद हमें देखना पड़ेगा कि क्या करेंगे. Yeah, and a lot of it in India, it is this information has to be laced with the financial angle also, कि इसमें लगभग इतना खर्चा आ सकता है, but it could be less or more. And you have to keep checking that he's understood, is he ready to go to the next level or not. So that's the other thing, that when you are sharing the information, like I said, pauses are important. You may have to repeat it also. You may have to tell them, you at the end of the day, you have to tell them what all can you offer. That's important for them. Finances is important from, because here people are paying from their own pocket most of the time. And very wise it is to know when to stop. That's, you feel that it is going beyond you, better wait, let your consultant come. He or she will be probably be able to tackle it better, because by virtue of experience of handling such situations more than what you have done so far. You have to learn to address their emotions. It is important. We, if you look at it, most of the global decisions are based on data, facts, but they are not without emotions. Prime Minister Modi may decide to take a step ahead with France and not with Pakistan. Lot of it has emotional angle and baggage to it. So what I mean to say is, we cannot just say that that is not sort of relevant. It is equally relevant. We have to address them. Sometimes human touch is important, but again, that is also a double-edged sword. Touch to whom and for how long is important. A good way is that you, by a good way of addressing the emotion is to accept that he or she is having, I know it is upsetting. That in itself is empathizing enough to the patient. So you have to learn how to create your individual style to address these emotions adequately. Just dealing with the patient and not with the family or caregivers is not enough, because they also go through a lot of emotional turmoil. After all, their life is linked to this person whom they have come with. So you have to handle them also. Here, lot of times you have to handle them more, because उनके साथ आपको ज्यादा elaborate description देनी पड़ेगी while sharing the news. And so you have to may have to spend more time you may have to be give more detailed information. And that's where I would like, this third point is important. So many times they say कि डॉक्टर साहब हम गए थे वहां पर कानपुर में और उन्होंने 6 महीने लगा दिए टीबी का इलाज करते करते, बताया ही नहीं कि खांसी है तो लंग कैंसर हो सकता है. नाउ द अर्ज टू क्रिटिसाइज a fellow colleague who's sitting over there has to be nipped there and then. He may be wanting to share with you this information, but by criticizing that particular colleague, you have just made him lose faith in that system and not regain faith, certainly not regain faith in your system. It is important to understand that you explain to him why that doctor would have given him TB ka ilaj for a couple of months before going on for further testing. The reasons for that, because obviously he did it as a stepwise approach, but it is the onus is on us when the patient has come to us, that we explain to him that it is the stepwise approach that the colleague over there would have adopted. At the end of each session, it is important to summarize ki, okay, so what we've discussed is this, that there is a problem, this is the problem, it is moderately advanced, but there is treatment, and this is the treatment which we would like to follow. It would be about, say, a few months of treatment, and it might be about a lakh of rupees that you may have to spend from your pocket towards the hospital fee. So all this needs to be sort of explained to the patient yet once again when you are ending the session. And the session never ends without the next visit. It should be told, okay, next when we meet, we'll discuss this. So there is an element of uh, homework or to do work for him कि मुझे next time आना है तो ये करना है. And it should end with a note of partnership, not sitting on the pedestal high table that ab dekho tumne kya karna hai, kya hoga. No. And obviously in today's day and age, without documentation of this kind of counseling session, you know, and I know how many litigations have happened because there, and doctors have lost their case despite the fact that they worked hard on the patient simply because it was not documented well. So it is very important. At the end of the day, I would like to also tell you that in any given situation, 99% or 99.9% of the times, you will be able to offer hope, whatever realistically you can offer, that you should. But also, it's your duty to prepare them for whatever is adverse is coming their way. So, one thing that I'd like to say is that the task of this is a very important saying by Robert Bachman, which says that it's a testing ground of for the entire range of our professional skills and abilities. If we do it badly, the patient and the family is never going to forgive us. Even 20 years down the line, they'll say कि वहां गए थे SGPGI में, उस डॉक्टर ने बोला था इतनी बुरी तरह से गलत गलत बताया, हमें कुछ नहीं. They'll remember it till kingdom come. But if you do it well, they will not forget you, even though it may be a losing battle. So it is that important. This is just a small case that I thought. So there was this lady, and she had a huge cancer on which had spread all over the face, and she was just not ready to understand. And the families kept on saying, very often you will find in your practice, they'll say the patient is sitting on the stool opposite you, and they say, "Inko mat batana." They'll make that ishara. So uh, that's a very important thing, that the patient may not be prepared at the first visit. This lady, we had 3 sessions, and then she kind of conceded that, okay, I want to know, and she was told, and then she underwent treatment. All I'm saying is that first visit, first session may not be a good idea. Lot of times patients say that a patient's family says ki inko mat batana. You can you have to create your own style. You can say that we will not tell, but let me assure you, one, uh, 90% of the times they get to know with the number of visits that they have to come to the hospital. And two, it is in the long run, it is always better for the patient to know. He or she can be mentally prepared for the onslaught of treatment that we are going to give. That is also not going to be easy. And also, they can prepare their life. Ultimately, it is their life. So they can prepare for their life in advance. There is news about deterioration. So many times we have to share not just the news of diagnosis, also this time again you have to explain to the patient, sit down. There is by now some bit of rapport between you and the patient, and you have to share that this is a part of natural history, and this is what we realistically can offer. Do I have time or ho gaya? 5 more minutes, just ending. Death is the other thing which is quite often, you guys are sitting in the night and there is a death that has occurred and you have to handle it all alone. So it's an important thing. We must understand when we are posted in the ward and this kind of situation arises, that patient is now going rapidly downhill. He or she is not able to communicate verbally. It is the verbal communication becomes our duty, if at all, with the patient. It is the non-verbal cues that the patient is looking for till the time there is some coherence in his or her mind. You actually have to communicate more and more verbally with the attendants now. The responsibility, the dialogue is more between the you and the attendants. And once the death has occurred in the ward, the formalities should be carried out with greater degree of sensitivity. I can assure you, I have been witness to this, and you also would be. There are times when there is a death that has happened in the ward, and the nursing station, there is a lot of hee haw happening, chai samosa happening. I think that should be refrained on a human ground. I would say that these things, even if the nurses are doing and they are not sort of linked directly to that patient or that particular death, but still we need to respect that this has happened. And that is something that I think we should all deal with it more emotionally, that sister, please, not now. Or I don't mean sisters, I just mean any one of us. And also other indoor patients. There is one death in a general cubicle. The others, you will find the other patients are lying, sitting huddled in their corner of their bed. They are demoralized. So sensitivity on our part is of extreme importance. Who notifies the death? We break the bad news. Here, it is not the sister or the attendant. It is our duty, the senior person preferably, who informs the family that the patient, their patient near and dear, is no more. And you may have to go stepwise, that we resuscitated him and this is what happened and he did not. You may have to put some explanation, because we kind of owe it to them. They've lost their family member. So you may have to describe a bit about the resuscitative measures that you took. Again, pauses are important. Some bit of touch is important at times. And you may have to sort of address their emotions. Here, a lot of times violent reactions are there. If you are anticipating, sometimes you know that there is an aggressive party standing, then be prepared. Create stand across the nursing station when you're talking. There is a lot of security in the hospital. Be prepared to call them at a short notice. Not to sort of be aggressive with the family members, but sometimes they get violent and aggressive because they are unable to control their emotion. So there can be an occasion sometime during your career that you may need assistance from a neutral party. I think I'll just end it over here. So we just have to be this is an extension of the negative sort of not negative part of communication, but communication which is not going to bring a positive response from the other side, and we have to learn it more and more. If we don't learn it in a formal manner, life will teach us in our clinical practice. So with that, I'd like to say that if there are um, any incident you would like to share or anything that you would want to ask, we'll be happy to hear.